in the chat. All right, so starting out, we're talking about diabetic retinopathy tonight. And we're going to talk about the impact of diabetic retinopathy. What is diabetic retinopathy with some examples, how we evaluate and treat diabetic retinopathy. So first, it's very important to know the epidemiology. 30.3 million Americans over the age of 18 have diabetes. And surprisingly, about 25% are unaware that they have diabetes. The amount of people with pre-diabetes is even higher. And above the age of 65, 25% of people have diabetes and nearly 50% have pre-diabetes. This is a very common condition. 1/3 of Americans are at risk during their lifetime. Diabetic retinopathy is a leading cause of legal blindness in working age Americans and worldwide. The estimated prevalence of diabetic retinopathy in the US is 6 million people, and 1.34 million have vision-threatening diabetic retinopathy. So what is diabetic retinopathy? It is characterized by changes in the small retinal blood vessels, which then cause a series of damaging changes that we'll go over that can lead to vision loss. So basically, what happens is diabetes damages blood vessels throughout the body and in the eyes. And the two main ways it does that is, number one, it can cause leaky blood vessels. And then number two is it causes decreased blood flow, mostly to the peripheral retina, sometimes the central retina. And when they have leaky blood vessels and decreased blood flow, there's an increased production of abnormal molecules, including VEGF. And this is what leads to the true complications of diabetic retinopathy, such as macular edema, which is when macular edema means swelling of the center part of the retina. That's when the leaky blood vessels cause swelling. Vitreous hemorrhage, which is blood in the center part of the eye. And then retinal detachment, which is when scar tissue can pull off the retina, detach the retina. And we have some photos of this as well coming up. So we just went through this chart, but that's sort of the pathophysiology of diabetic retinopathy. Now, how we treat diabetic retinopathy is to really target these abnormal molecules that are produced. And the way we do that is with injections in the eye, laser treatment to the retina, and then if those fail or it progresses, surgery to remove the blood from the eye or remove scar tissue. So this is a picture of a normal eye, and then with diabetic retinopathy, you can see that there's damage to all these blood vessels. And the pathology, and this is basically the underlying cause of diabetic retinopathy, is changes to the blood vessels by the loss of retinal capillary parasites and changes to the capillary basement membrane, which leads to vascular hyperpermeability. And we can see early signs on our retinal exams in microaneurysms, which are these outpouchings of the blood vessels, and that shows damage. Now, there's various stages of diabetic retinopathy, and the more advanced stage that causes damage to the vision is proliferative diabetic retinopathy, and we call it PDR. And PDR is when abnormal blood vessels start proliferating or growing from the retina. And you can see a photo here. You know, these are all these little lacy blood vessels or abnormal blood vessel growth from poor blood flow from diabetic retinopathy. PDR can lead to retinal detachments from pulling on the retina, vitreous hemorrhage, and you can see a photo here. This is blood blocking the retina, as well as neovascular glaucoma, which is when abnormal blood vessels grow and block the drainage system of the eye and cause the pressure to go up, which is glaucoma that can damage the nerve. So how do we sort of help diagnosis. So questions we ask all our patients who come in for screening for diabetic retinopathy is the age of onset of diabetes and duration. We obviously want to know type 1 or type 2 diabetes, as well as their hemoglobin A1C, which is a marker of blood sugar control. And then we always ask about high blood pressure because high blood pressure was also shown to worsen diabetic retinopathy. And then we do a complete eye exam. We look at the front of the eye. This patient has abnormal blood vessel growth. You can see those are abnormal iris vessels. And then, of course, we look at the retina centrally and peripherally. Other testing that we get in the office includes the OCT test, which lets us look for edema or swelling. And then this is a fluorescein angiogram, which is a dye test where we inject dye in the patient's blood vessel in their arm. It travels to their eye, and we can see areas of abnormal blood vessel growth, like you can see here where my mouse is, which is leakage on the dye test. Now, treatment. How do we treat this? One of the mainstays of treatment of proliferative diabetic retinopathy is laser treatment to the peripheral retina called pan-retinal photocoagulation. And on this image, you can see multiple spots of laser treatment in the peripheral retina. And what this does is it inhibits growth and facilitates regression of the abnormal blood vessel growth. We do this in the office, usually in about a couple 10-minute sessions, in order to really laser the peripheral retina. And it was shown in studies to reduce the risk of severe vision loss in patients who received PRP. Other treatments, when someone has a bleed in their eye, we usually start with injections to help treat the abnormal blood vessel growth. If the blood doesn't clear with injections, then sometimes we do surgery called a vitrectomy to remove the vitreous gel and the hemorrhage. And then one of the worst complications of diabetic retinopathy is a tractional retinal detachment. And that's when these abnormal blood vessels pull on the retina and cause a detachment. And these are usually treated, and this is a picture of a tractional retinal detachment, and these are usually treated with vitrectomy. The other complication of diabetic retinopathy is edema or swelling. And these are OCT images of those dark spaces or fluid in the retina. And DME is treated usually with anti-VEGF injections in the eye. That's our mainstay of treatment. And luckily, patients with diabetic macular edema or diabetic swelling can recover substantial amounts of vision. And oftentimes, if one anti-VEGF agent doesn't work, we can switch to another one. And we can also supplement with injections of steroid medication into the eye. You can see one option here, Ozurdex. And that Ozurdex is effective for 3 months, intravitreal dexamethasone. The reason that oftentimes we don't start with steroids right away, usually it's a combination, is because steroids can cause the eye pressure to go up and it could also worsen cataracts. So this is a photo of diabetic retinopathy, and you can see the significant changes affecting the blood vessels and the swelling there centrally, and you can see the difference between a normal retina and a diabetic retina, and here as well. And here are other images, and this is a patient that has vitreous hemorrhage. There's a bleeding there. And this is a patient that has a tractional retinal detachment, like we discussed. This is what an OCT scan looks like when you see your retina specialist or general ophthalmologist. We are able to take a cross-sectional image of the center part of the retina to look for swelling. And this is a good image that shows an OCT, which was the past scan, and that top image has diabetic retinopathy with macular edema. And then after injections, that edema improves, and you can see that the swelling, the dark spaces of fluid are better. So risk factors for diabetic retinopathy include duration of diabetes, blood sugar control, blood pressure control, as well as cholesterol. And the natural history of diabetic retinopathy is that it progresses from mild to more severe stages. And a lot of the clinical research has been done, are 90% effective in preventing the occurrence of severe vision loss, but early detection is very key. Someone can have 20/20 vision and no symptoms and have vision-threatening diabetic retinopathy. Oftentimes, it can start in the peripheral vision, and people are unaware. And that is why most primary care doctors, and the recommendation is yearly dilated eye exams for anyone who has diabetes so that this can be caught and treated sooner. That eye exam includes obviously a dilated eye exam, the OCT scan, which shows us the center part of the retina to look for fluid or scar tissue. And then oftentimes it can include the dye test, the fluorescein angiogram, which is when a yellow vegetable-based dye is injected into the arm, travels through the blood vessels into the eye, and it very specifically looks at the blood vessels in the retina. In summary, to treat the diabetic macular edema, we do injections of anti-VEGF medications and steroids, sometimes laser, though we've moved away from laser for this particular condition. And then the proliferative diabetic retinopathy, the injections, but the mainstay is the laser treatment. And of course, surgery, if the other treatments fail. This is an image of intravitreal injections. We inject it about 4 millimeters from the cornea into the vitreous cavity so it can get to where it needs to go. And any questions? Stop sharing my screen.
So for questions, please feel free to write your questions in the chat and we will review them. And if you like, if I don't get any questions, I may just turn everybody's volume on so you can ask them directly. So I think that's what I'm going to do, Dr. Padidam. One moment, please. So I have opened this up so that you can take yourself off of mute and ask any questions you like. Gosh, I guess I'm going to start with one question, Dr. Padidam. Does blood pressure have anything to do with diabetic retinopathy? You mentioned some of the other things.
Yes, uncontrolled blood pressure can worsen diabetic retinopathy, and that's been proven in studies. So when I see a patient with diabetic retinopathy as well as hypertension, I try to ask how their blood pressure control is as well.
I see it. Question.
Go ahead, Carol.
Okay. Does this relate to glaucoma?
Good question. Glaucoma, the definition of glaucoma is damage to the optic nerve that is associated with high pressure. Mm-hmm. And while diabetic retinopathy is not associated with glaucoma, primary open-angle glaucoma, which is what we think of when we say glaucoma, uncontrolled diabetes can cause abnormal blood vessels to block the drainage system of the eye, causing a condition called neovascular glaucoma, which is very hard to treat and usually requires surgery with a glaucoma specialist. So while glaucoma doesn't put you at a risk for diabetic retinopathy, very uncontrolled retinopathy can cause this complication, neovascular glaucoma.
So is the most important thing to keep your blood sugar to prevent getting diabetes as far as...
Yes, and if you are diagnosed with diabetes, the most important thing is strict blood sugar control. The better your blood sugar control is, the better people do in the long run. And it's a tough condition because some people may have uncontrolled blood sugars for 5 to 10 years and then get them under control. And then I see them and they're, have wonderful blood sugar control, but a lot of the damage is already done. I tell my patients it's a cumulative effect. All that poor blood sugar control over the years affects the blood vessels. And if 10 years later you have better blood sugar control, a lot of damage has been done already. Mm-hmm. So from diagnosis it's very important to have good blood sugar control from the day of diagnosis.
Thank you.
Thank you.
Good evening. My name is Alexis Johnson.
Hello.
Just a little background on my case. I'm type 1 diagnosed at 27, 14 years ago. I suffered from diabetic retinopathy in June of 22. I had a perfectly normal eye exam. And that same year, I contracted COVID. After that, I noticed a sensitivity to light. By March, by March of 23, um, I went to a retina specialist, and after a routine optometry exam, and was diagnosed with diabetic retinopathy. They said there was no hope for my right eye. However, the retina specialist did perform laser surgery on my left eye, which caused a hemorrhage. And then eventually I had to have surgery to reattach my retina. Since then, I am on a couple of different drops to keep my pressure down. But my healthcare team has not recommended any type of treatment. Is there any treatment going forward? I do have a loss of vision. I consider myself visually impaired or low vision. I do have some vision. So I'm wondering moving forward if there is any treatment.
That really depends on, if there's been damage to the center part of the retina from diabetic retinopathy in the past. It sounds promising that, your better seeing eye had laser treatment, which is very necessary in proliferative diabetic retinopathy, as well as surgery to fix the detachment. But unfortunately, it is a tough condition where if there's poor blood flow to the center part of the retina, from diabetic retinopathy, it can cause poor vision that's very hard to treat. But I would definitely talk to your retina specialist about what other treatment options, or if there's anything that can be done to improve your vision. You never want to give up hope, and there's always research, as you know, being done in these conditions. So I think it's good to sort of definitely check in periodically.
Okay, thank you so much.
Yeah.
And Alex Van Veen, I had to mute you. So if you have a question, please take yourself off mute again. There's just some background noise that came through for a moment. Michael Harrington.
What are the similarities between uveitis and the diabetic retinopathy?
Good question. So uveitis is sort of a different pathophysiology, but some forms of uveitis also can affect the blood vessels, inflammation of the blood vessels like vasculitis. Some forms of uveitis can also cause abnormal blood vessel growth. However, the underlying pathophysiology of diabetes is damage to the blood vessels, which is different from the underlying pathophysiology of uveitis, which is more related to inflammation of various parts of the eye, whether it is, anterior uveitis. Uveitis can cause macular edema. So while some of the findings can be similar, the underlying cause is different.
Thank you.
Are there any other questions?
This is Alexis again. I do have one more question. Have you seen any link between COVID and diabetic retinopathy? Like, how would it accelerate a case of diabetic retinopathy. I know that when I had COVID, I was intubated, and the doctor is conjecturing that there was a link between the COVID and diabetic retinopathy.
So I'm not sure if it's been proven in studies that the COVID-19 virus itself accelerates diabetic retinopathy, but if you have COVID or you're in the hospital or intubated, if the blood sugar is out of control, that accelerates diabetic retinopathy. And then I've seen, unfortunately, with COVID, it's been harder for people to access care and see their doctors. And I've seen many patients sort of come back after COVID with significantly worsened diabetic retinopathy. So, it definitely has affected our patient population. But I can't say that there's a direct link between getting COVID and worsening retinopathy. Of course, this is something that's still being studied. We don't know everything about how COVID affects the eye and the body. So as of now, I'm not aware of that, but that's not to say they won't find a link.
Okay, thank you again.
So Dr. Padidam, you talked about uncontrolled sugar, and then you also mentioned that there's a significant portion of our population over 65 that are pre-diabetic. Is there a line? Can people go back and forth between having diabetes and pre-diabetes that might lead to some eye issues, or how does pre-diabetes fit into this? You can review that. That would be terrific.
Great question. So thankfully, usually if people are pre-diabetic, their blood sugar is in a certain range that does not usually cause damage to the retina. So when I see a patient who is pre-diabetic, I'm happy to see them and screen, and that's good, but it's very unlikely, you're very unlikely to have any form of diabetic retinopathy, thankfully, because, the definition of pre-diabetic is your blood sugar controls in a certain range, and in that certain range, it should not be negatively affecting the retina. I think the important thing about pre-diabetes is just to take that as a kind of warning sign and make sure it doesn't progress to diabetes. But there's no screening for patients with pre-diabetes. They don't need, yearly retinal exams or anything like that.
Thank you. That's very helpful. Are there any other questions? David?
Hi, I have a question. I'm not sure if I'm asking in the right terms or if I'm going to use the right words or not, but I recently had a vitrectomy done in my right eye, and my right eye was my better eye, and my eye doctor had treated it with lasers over the last 15 years. And then when the surgeon that did the surgery was another doctor in my clinic who did it, and he was talking to his team as he's working surgery, and I overheard some stuff, and afterwards he explained it to me. But he was saying basically in the lines of that this is a case where this patient should have had a vitrectomy years ago instead of numerous laser treatments, because they see the laser treatments all around my retina and that it's all clean. But he was saying that a vitrectomy would have stopped the bleed from going to my central vision and causing the vision loss. So I was confused, like, why wasn't that maybe considered in the past? What could have been reasons or something?
Yeah.
And then now the doctor's also saying, the surgeon who did the surgery, he said that anytime I have a bleed now, the vitreous gel will move the blood to the back of the eye and will likely not enter my central vision, so that I'm more safeguarded against losing further vision. Is that true?
To answer your first question first, it's hard to say exactly, what the thought process was without, knowing all the details about your case. But, oftentimes surgery does have risks. And while the in-office laser treatment is, I don't want to say safer, but lower risk, and it is the first line treatment of proliferative diabetic retinopathy is good peripheral laser. And oftentimes, especially many years ago, vitrectomy was not as advanced as it is now. And, you know, the tools they had 10, 20 years ago, I'm not sure exactly when you were having laser, the threshold for doing vitrectomy was much, much higher because it was a riskier procedure. Now with our very small instruments, we have a, you know, lower threshold for doing a vitrectomy, but that may have been the thought process. And then to answer your second question, after the vitreous gel is removed, if there is another hemorrhage or bleed, usually the eye is able to resorb the blood faster, as opposed to when the vitreous gel is still there. So after a vitrectomy, if someone does have a vitreous hemorrhage, it usually resolves quicker.
I see. Thank you. And then can I ask a couple follow-up comments and questions?
Of course.
So I had a vitrectomy on left eye 15 years ago or so.
Mm.
It was like the third or fourth visit I had with my eye surgeon at that time when I first got diagnosed with diabetic retinopathy. And yeah, I agree with your comment because there's a night and day difference between my left surgery 15 years ago and my right surgery just a couple weeks ago.
Mm-hmm.
The experience was totally different, and the pain, the healing. Like the gas bubble just left my eye about a week ago, and I'm seeing clearly, and my eyes not swollen like it was when my left eye was done.
Mm-hmm.
And then shoot, I think I just forgot my second question. Maybe it'll come back to me. I might ask later. Thank you for your answers, though.
Of course.
This is Carol. Do you have any recommendations as far for related to prevention, like as far as diet, what to avoid, what things are good, what things aren't?
Definitely. Everyone is very different, but I think what's important, and if this is to just prevent diabetes, is to, you know, just sort of watch your diet and kind of all the things your primary care doctor says, you know, eat green leafy vegetables, be careful with processed food and sugars, and exercise is very important. And I have patients that, you know, are diagnosed with diabetes and then do a lot of different lifestyle modifications with healthy eating, weight loss, exercise, and they're able to have something called diet control diabetes, where they're not on any medication, or they're on, you know, metformin, just one pill. They don't need insulin, and that's, you know, they're able to do that through sort of strict diet and exercise. But I think preventing diabetes is important to follow those principles, and then just see your PCP for labs once a year to make sure you know, you're not developing diabetes.
Thank you.
Well, terrific. I am going to ask one more time for questions in case there's some people who have been waiting for their moment. This is your moment. But I am so glad that you all have joined us today, and we will definitely do another one of these again. And Dr. Padidam, thank you so much. Such valuable information, and this really is something that we're hearing more and more about.
Mm-hmm.
And so I'm thrilled that people are beginning to talk about it more, and that we also are beginning to talk about it. So thank you all for joining us. We greatly appreciate your time this evening, and stay in touch. We have another education event this next Tuesday, February 6th. It's with Dr. Miriam Mathai, and she'll be talking about age-related macular degeneration. So it's another topic of great interest in our area. So thank you so much for joining, and I wish you all good health. Thank you.
Thank you.
Thank you.
Have a good night.
Good
You
night.
as well. Thank you.
Bye-bye.